So this is a patient who's a young 37-year-old female who's a housewife by choice. So she is a resident of a nearby town called Tirupur here. So she presents with a history of altered bowel habits for the past and pain abdomen for the past about 1 year. So she's basically presenting with altered bowel habits, predominantly loose stools, right? So that is a chief complaint. So when it comes to the evaluation, the loose stools has been for about 6 to 8 times per day. It's almost, most of the times it's been associated with blood or mucus. This is some warning sign about this patient, which has to be kept in mind when especially a patient is complaining of a chronic abdominal pain associated with blood or mucus. The pain abdomen is in an inflammatory bowel disease is sometimes very vague. Sometimes can be cramping, it can be generalized, it can be aggravated like a gastritis with food intake or associated with passing of stool. So abdominal pain really doesn't play a huge role in inflammatory bowel disease unless you have some obstructive features or stricturizing diseases and things like that. So, but she has already, this patient particularly has been evaluated in a hospital outside and has been already diagnosed to have ulcerative colitis, and she's already been treated with certain drugs. With this presentation, patient has been absolutely normal 1 week prior to the present scenario to our hospital. So when she presents with 1 week of bloody diarrhea and abdominal pain, what do we usually suspect? Any takers from the audience?
If you have any, but you would like to write something in particular regarding the question, please write it on the chat box.
Yeah, if you can answer unmuting, it's fine. Otherwise, if you put it in the chat box, yeah. Otherwise, it gets boring. So anyway, so if there is no, usually what you need to suspect.
So the basic question here is, doctor.
Yeah, if the patient presents like this, what is the usual suspect in an inflammatory bowel disease? Patient presents with a 1 week history of loose stools and pain abdomen and things like that. What do you usually suspect? Yeah, I have one answer. Ulcerative colitis. Yes, Dr. Neena. The patient has ulcerative colitis. The question is that, okay, we'll elaborate. So whenever patient is already diagnosed with ulcerative colitis or anything, even if you have such a presentation, infection flares are something which is very common these days. So first you need to suspect an infective flare, whether it is diagnosed case of IBD or not diagnosed case of IBD with ulcerative colitis. Always keep your infection as a first option, right? So, but this patient is associated, has a history of 1 week prior history of fever, chills prior to the admission, has generalized fever symptoms like weakness and myalgia and things like that. Let me rush. Otherwise, the personal past history, there's been nothing significant in this patient per se. She had a normal pregnancy. Everything has been fine during her pregnancy. All the symptoms has started in the last year or so. Yeah. So in this, a syndromic diagnosis will be with the background history of ulcerative colitis. This patient has presented with altered bowel habits, bloody diarrhea, pain abdomen, tenesmus with a possible episode of fever, which suggestive of most probably due to the flare of an infection or a natural history like an ulcerative colitis getting flared by itself. So this will be the syndromic diagnosis in this patient. So when you go to the examination, patient is moderately built, decently nourished. She's been eating well despite all the bowel habits and everything. She's conscious oriented. She's affable during the presentation, but her weight is just 46 kg. BMI is around 18. She looks very pale on examination since she has a bloody diarrhea. And even though she says for a week, she looks too pale for even for a weak patient. Yeah. Other than that, there is no signs of heart failure. There is no elevated JVP, no other features of any chronic malnutrition like oral ulcer, stomatitis, and things like that. So she's been reasonably preserved. Not great, but she's been reasonably preserved. On clinical examination, inspection of the abdomen is pretty normal. Everything is normal in shape, size, and there is no obvious sinuses, scars, and there is no obvious redness or anything of that sort. Her palpation, there is mild tenderness on deep palpation, which is very vague. There is no specific localized area of tenderness or guarding or rigidity. Basically, we're not trying out anything of an acute abdomen here. Percussion and auscultation are equally normal. So when it comes to the perrectal examination, we can clearly find there is a blood stain in the fingertip. Yeah. So other system examination has been reasonably normal. So the first line of investigation in such a patient will be blood counts, ECRP and an ESR, and another for the nutritional markers, we take albumin and protein as a surrogate marker. So when it comes to this patient, surprisingly, on presentation, the counts are pretty normal. Our first suspicion was infection, but the counts are pretty okay. 7,400 is not a bad count. When it comes to the pallor part, she's definitely anemic, and which is established in this evaluation of the blood investigation. Alarmingly, the CRP, a cutoff of 5, the patient has about 58.8. ESR, again, spiking up to 101. And patient has an albumin of 3.1, just below the baseline. So in such a scenario, associated with that, patient also, because of the dehydration, possibly, and the GI loss, has coexistent dysalactolemia. This is the basic setting of this patient, which you do in a clinical practice. So what do you do next is the question. Do you stop with this? Do you do anything? Any takers?
So what do you think is the next step here?
Next step, yeah. Okay, we'll move ahead. Okay. So,
Endoscopy?
Endoscopy, yeah. Okay, Dr. Nina. So before going that, we did a few investigations apart from this, and we did.
Doctor, we have one more suggestion, that is by Dr. Surya, IV fluids.
IV fluids, excellent. Yeah. Hydration and all those things are very crucial, doctor. When it comes to evaluation part, like endoscopy is crucially important. Before that, we tend to do certain blood investigations and certain non-invasive markers of IBD per se. So in this whole chart, the routine blood and stool, I mean, the stool culture and the stool routine is, I mean, I'm sure everybody understands that part. But when it comes to this portion, this is what I want to highlight in this. So the fecal calprotectin is a surrogate marker of an underlying inflammation. Fecal calprotectin is a acute phase reactant which is shed in the stools, which gets elevated in a patient with IBD. So even when patient doesn't present with a very obvious cross bleeding and things like that in stools, sometimes patients are symptomatic with increased bowel habits and other symptoms. Always go an extra bit and get this fecal calprotectin, which is a stool test to be done. The normal cutoff is somewhere between 50 and 100. This patient had 1,500, right? Apart from it, you just do a basic X-ray abdomen so that you are ruling out anything like a sinistral complication like a toxic megacolon. The other parts are routine. The Clostridium difficile and CMV sometimes are not available routinely, but in an IBD patient who's already been on immunosuppressants, should pay attention to it. But that's not the emphasis here. Our emphasis will be to go ahead for a fecal calprotectin. Like doctor who suggested an endoscopy, we always go back to the previous endoscopy and decide on the extent of the disease. Whenever patient has inflammatory bowel disease, the extent of disease is somewhat very crucial. This patient in particular had a predominant left-sided colon with partial of the transverse colon. Coming in any way you cross a mid-transverse colon, the severity of the disease is almost taken as a pancolitis, right? So in this case, it's not a pure left-sided disease. She has rectum, sigmoid, descending, and transverse colon involvement, which is almost an E3 disease. The extent is almost E3. That's the various markers which we use to mention. So we can take this patient as a pancolitis patient. So when this patient underwent an unprepared sigmoidoscopy, we don't want to again prepare the bowel, clean the bowel, and go ahead with all those things because patient is actively symptomatic and she has blood in stool. So we did a unprepared sigmoidoscopy. And what we found here is the description given here.